Thank you, everyone, members of the press, for joining today. Today, this is a profound moment as I'm able to be joined by two powerful women, doctors, women of color, Dr. Zenia Jankir and Dr. Dul Dalal, to be sharing with you all race and ethnicity data. This is data that is so needed for us to be making decisions about policies, decisions about resources, decisions about how we're going to fight this global pandemic. We're going to share this data with you today, but it's important to understand the history of this that precedes this data, a history that makes some people more vulnerable, not because of choices they've made, not because of their age, but simply because they were born Black or brown in a society that's treated them and their ancestors unfairly. This data that we're going to be releasing is it's addition to data that we've released on the data dashboard about a month ago for the region, including Clackamas, Washington, and Yamhill. But this data is rich and powerful and has an additional story. We get our data from lab results, either directly from the lab or from interviews once we're interviewing people with positive cases. But we know that all of those data points tell a story, that they are human beings, that they are people who have families, who have lives, hopes, and dreams. And we understand that simply sharing data is more, and it's not just our story to tell. So with that, I'm going to pass it over to Dr. Zenia Jankir.
Great. Thank you, Ms. Mitchell. Good afternoon, everyone. Again, my name is Dr. Zenia Jankir. I'm the director at the Oregon Health Equity Alliance. We're one of 6 regional health equity coalitions across the state of Oregon. Thank you for the opportunity today to talk about the importance of disaggregated data, who's telling that story, and what is different this time for Black, Indigenous, and people of color communities. I want to begin by honoring the immense wisdom and strength of Indigenous, Black, and Brown communities, not just in the time of COVID-19. Many of us carry our ancestors with us, and while the resilience we experience is undoubtedly tied to a long history of colonized, racist, and xenophobic policies, practices, and actions, it is also a result of inherent strengths in our community, rooted in intergenerational wisdom, collective care, and community-oriented practices. At the Oregon Health Equity Alliance, our work is really guided by a commitment to racial justice and health equity. We believe health equity is rooted in dismantling and shifting oppressive structural and systemic practices that impact and affect individuals and communities' ability to thrive. We believe health equity is achieved when every person has the opportunity and resources, power, and autonomy to attain their full potential. Current policies and practices, decision-making, and program development often leaves Black, Indigenous, and people of color communities out of solutions that are subsequently implemented in their own communities. Efforts to be more equitable fall short when they are not meaningful and do not include accompanying resources, power, and conditions for self-determination. The social determinants of health narrative often bypasses colonization and racism, the impacts of transphobic and xenophobic medical systems, and the deeply entrenched anti-Blackness that exists in all systems. The systems we look to protect our communities have been built using frameworks, foundations, and solutions that will never serve many of our communities. Regarding data, as my colleague Dr. Andres Lopez said yesterday, the importance of data is that it's used to define and control knowledge production. It is central to making decisions on funding. And what the story the data often tells is that it portrays our communities negatively, knowingly or not, through a biased lens. I believe without clear, complete, and disaggregated data, our communities continue to be told the data doesn't exist, or we're waiting on the data before we can direct resources and programming and funding your way. Anyone that's listened to community members most impacted by health inequities can tell you that they have used their powerful voices to tell us over and over that they are suffering, that more culturally responsive resources are needed, and that more money and less strings for local solutions are required, and yet resources and services are not equitably allocated. Disaggregated data that is shared with communities most impacted first allows those communities to create their own narratives. Far too often we see these narratives created by people outside of the community, by people who are not talking about root causes, and those who are not fully aware or do not want to believe that racism is real, that colonized systems exist, and that there is a role for all of us, every single one of us, in dismantling these systems to provide an opportunity for all of our communities to thrive. When data is not disaggregated or is incomplete, it reinforces social inequities. Another colleague, Dr. Kelly Gonzalez, grounded us yesterday and reminded us that decolonizing practice is really an integral part of health equity. This COVID-19 pandemic is an incredibly traumatic time for our Indigenous, Black, and Brown communities, but we need to be clear that this trauma is on top of existing trauma faced by our Black, Indigenous, and people of color communities, and a result of a long history of colonization, racism, violence, and exclusion. Moving forward, we must build with our communities most impacted, listening to their needs, their solutions, and grounding in healing. Our world will never be the same, and we should use this opportunity to create truly equitable systems, structures, policies, and programs with communities that are most impacted, centering them in all of our decision-making, including the allocation of resources. We're so incredibly thankful to the leadership at the Multnomah County Health Department to ensure data is collected using the Real D data disaggregation forms, an advocacy effort that many of our BIPOC communities were advocated for in 2013 and have really allowed us as a county and as a state to stand out and say, we really believe in disaggregated data, not just for the sake of collecting these data, but to ensure that these data are used to better resource, fund, and center our communities impacted. I'm done, so I guess I'll Dr. Deldelau.
I was getting a little exhausted from constantly nodding my head to what Dr. Jenkir was saying. So once again, my name is Dr. Eileen Deldelau. I am a research scientist and senior epidemiologist with Multnomah County Health Department. So, and I also use she, her pronouns. I wanted to take a moment first to acknowledge my colleagues, the infectious disease epis, which this work would not have been possible. The folks really on the ground doing a lot of the interviewing and the case investigations, the tracing, the crunching of the data. So I just want to take a moment to acknowledge the work of Russ Barlow, Taylor Pinsent, Kevin John, and Ellison Fortney, who I work really closely with, and we work with to understand the data, understand the caveats of the data. So I am a woman of color. I am the daughter of Filipino immigrants. I come from I've been categorized as a Filipino, which oftentimes is a category that does not show up on different ways that we measure data. I'm put in the Asian Pacific Islander category, which is actually, if you ask my parents, they do not identify as Asian or Pacific Islander, they identify as Filipino. So I want to make sure that, yes, we want disaggregated data, but we also need to understand that many of these categories, these racial categories, are socially constructed, and understand why we use these categories. We are using these categories as a proxy for experiencing racism and how racism shapes people's experiencing of the COVID-19 pandemic. So, we see this, what Dr. Jenkir was talking about, across the cases nationally. Black, Indigenous people of color are more likely to be exposed to coronavirus because they're more likely to engage in public-facing essential work. So working in grocery stores, in janitorial services, working as nurses. Severity, we see more severity among Black, Indigenous people of color because they are more likely to experience severe symptoms and hospitalization because of racial disparities in chronic disease, less access to healthcare and opportunities for health. We also see disparities in mortality or deaths. Black, Indigenous people of color are more likely to die because of higher rates of chronic disease in both young and old. So these underlying conditions that we often hear about that exacerbate what people experience with COVID-19. And what we see nationally, what we see locally is actually reflected in what we see nationally. So if you've taken a look at our dashboard, it shows the number of people who have been ill with COVID-19 by age groups, race and ethnicity, and sex. And so I want to make sure, just to mention that this only shows people who have had access to testing. So we also look at housing status, which is also displayed. And we include this information on our dashboard to help our community understand that COVID-19 might impact groups differently because of inequitable testing and inequitable risks of exposure and equitable access to medical care and testing. And so essentially, people in our communities have differential access based on their experiences with discrimination and racism, colonization, and historical trauma. So this data can help us stop the spread by understanding which communities are most impacted by health inequity so that we can allocate resources in a way that is equitable and is in response to what we see in the communities. So again, I want to remind you that the data that we see in the dashboard is based on who has access to testing. So once we ramp up testing, most likely we will see a lot more cases. You'll see a lot of more disparities. We will also see a lot of the patterns of racial disparities that we have seen in Multnomah County. The numbers are small, but the data does suggest that at least 40% of the cases are among Black, Indigenous, and people of color. Again, why are we seeing this? Black, Indigenous, people of color in our county are more likely to hold these essential public-facing jobs. They're less likely to have the privilege of teleworking. And also, we see a lot of communities who are very tight-knit and have close social networks. And so we also know that, proximity to people is one way that COVID-19 is spread. So we are also seeing in our county that we are seeing more severe outcomes in people with underlying chronic disease like cardiovascular disease, diabetes, and lung disease. Even though we have small numbers, the data does suggest that Latinx and Asian Americans are more likely to be hospitalized. And when we drilled down in those cases, we saw a lot of underlying health conditions. And that is true across race and ethnicity. So Black, Indigenous, people of color have higher rates of these underlying conditions that exacerbate COVID-19. So once you introduce that into communities with a lot of chronic disease, when you introduce coronavirus, it becomes it's a compounding factor and it becomes really concerning. So among the deaths we see in the county, most have underlying health conditions and are older adults. And we also know that this is directly related also to the fact that African American and Black residents have higher rates of heart disease. So having that underlying condition of heart disease, if you get coronavirus on top of it, that will lead to much more likelihood of being hospitalized, being put on a ventilator, and also from dying from coronavirus. There are limits to the data, as there are to any data that we see, especially now because we have, our data really is reflecting a lot of the limitations regarding testing. And so, we have a lot of small numbers, and the small numbers that we're seeing, again, largely due to the lack of testing, will significantly change the percentages that we see. We also have to understand that race and ethnicity is something that, the gold standard is people that are allowed to self-identify. And now, people are not always allowed to self-identify or have the opportunity to self-identify. We have to understand that there's different points at which people are able to mark their race ethnicity. There's the point at testing, there's the point at the case investigation, and there's the point at which people unfortunately die from COVID-19 and then also have their race ethnicity recorded. And so we also have to realize that there can be areas or times where race ethnicity is not accurately recorded. And so even more so why we need to collect data using the REAL-D framework, which allows not only for the collection of granular race ethnicity, but also language and also disability. And so it's incredibly important that we collect that data not only to understand how language access and disability affect the numbers that we see, but the intersections that we might see between race, ethnicity, and especially disability. So we do have a lot of missing data. I'm gonna drill down this testing issue because I was taught in grad school that if it's not measured, it doesn't exist. And so I think that that's something that we have to really keep in mind, is that we really need to understand that not having all of the testing data, not having a lot of testing, is really hiding a lot of disparities that we may see. So we do need reliable data to trust that we have the testing we need where we need it. We have to also understand and look at the data and understand that nearly half of all the testing data omits race and ethnicity. I've seen that data myself. Unfortunately, we are missing that data for almost half of all the electronic lab reports that we get. And that means that we don't know accurately who has access to testing and who doesn't. But that doesn't mean that we can't act on what we know about the way that disparities work in our communities. I've said this before in my last talk that it's a different disease, but it is coming to be the same story. And the same story in that it is the same pattern. Unfortunately, what we also have to realize, it's the same story in that a lot of the disparities that we see, people are accepting as the status quo. We can't let that happen again. You know, we know that there's racial disparities in maternal mortality. We know that there's disparities in infant mortality, right? We know that Black babies are twice as likely to die as white babies. So knowing this and moving forward, we need to act on the information that we know so that even though we don't have testing and really accurate information, we do know our communities and we do know how racial disparities play out across our communities when it comes to health. Thank you.
So with that, it's a call to action. It's a call to action for all of us. It's a call to action for our healthcare system. We, looking at this data, cannot sit back and let this data deepen health inequities. And so what does that mean for us? For all of us, we know that the actions we're asking you to take are harder for some people and they're a privilege for other people. We know that teleworking or physical distancing is much easier if you can telework. We know that it's easier to stay away from a sick family member in a 3,000 square foot house than it is in an intergenerational apartment. We know that working on the front lines is much more of an exposure, and we all need collective solutions for that to be able to protect our most vulnerable and beloved communities. For healthcare systems, we need you to collect race and ethnicity data. We need you to be asking each and every patient that you come in contact with, what is their race and ethnicity based on the Real D categorizations. We need that to happen for every lab. We need it to happen for every visit. And for individuals walking into healthcare settings, ideally you would be asked, but put it out there. Tell people, this is what I am and this is how I want to be categorized. And I expect in my healthcare that my identity is accurately reflected. We need health systems to ensure that Black, Indigenous, and people of color have the access to the testing that they need. We know that is so important for us in making decisions in public health, for understanding what's happening, and for communities to trust your health systems that they are getting the care that they need and deserve. We need you to use the Real D classifications and continue to do everything you can to reduce barriers to testing, whether that's cost, whether that's language access, and work with us to hear from communities about what the barriers are and what they want us to do about it. For all of us, we ask you to continue washing your hands, doing your best to maintain physical distance. If you're comfortable with it, wearing face coverings, also acknowledging that face coverings is also an area of privilege. It's harder for folks with disabilities, hard of hearing, and quite frankly, Black and brown folks being scared about how they're gonna be perceived and if they're gonna be perceived as a threat from wearing a mask. But that's an action, a voluntary action. We're asking you, Black and brown people, to stay, and everybody else, to stay on top of your chronic diseases. Here at Multnomah County, we are open for you. We have health clinics across the community. We're taking new patients. We will help in a variety of ways. We have telehealth appointments. We have clinics that are open for business, and we also have testing for sick folks. So if you need to get enrolled in our services, please give us a call, 503-988-5558. For community members, please visit our website. We have our website in multiple languages. That's multco.us/COVID-19, multco.us/COVID-19. For communities, please stay connected with your loved ones. Call your neighbors, call your abuela, check in on your grandparents, check in on your friends and family. Let's continue to be in this together, and let's continue to bring the resilience and brilliance from Black, Indigenous, people of color into this solution. Thank you.
Thank you all. I'm going to unmute Julie and myself. And now if folks have questions, there are a lot of ways you can do that. You can text Julie. You can raise your little blue hand. You can chat us here.
While we're waiting, I'm wondering if Dr. Junkier could talk a little bit about the Oregon Health Equity Alliance and this partnership that you're in with Multnomah County.
Yeah, absolutely. So, you know, we've had a long-standing partnership with Multnomah County through one of the projects, in particular, the Multnomah County Community Health Improvement Plan, or Community Powered Change, as we term it. We're at the end of our 5-year investment now, and it's just been, you know, such an incredible opportunity to have a community-based organization and a county collaborative. I think it was the first time in the state, and frankly, I think in many states across the nation, to have a culturally specific community-based organization that was really leading the local community health improvement plan. And, you know, in all transparency, and I'm sure Ms. Rachel would say this too, right? These kinds of relationships are not seamless. They're not without challenges, and here we are 5 years later, and I think that it's been such a great opportunity to build strong relationships with our local counties, our local you know, officials, as well as you know, allies who are working every day internally to not only mitigate for the racism and all of the other impacts of the structures they're working within, but to try to do things differently as a public health department. And so, yeah, we that's, you know, one of the ways. And then there's a whole host of other ways that we stay connected as well. That's one of the main ways.
We have a question from Nigel Jaquis. Dr. Rachel Banks, can you explain a little bit about how testing will change and what the turnaround time will be? For example, results in how many hours or days, and what exactly will Multnomah County's role be in ensuring more equitable allocation to testing?
Yeah, well, you know, as has been said, we want to see an increase in testing, and as testing capacity gets better and is quicker, that's an advantage to folks too, as it tells you what to do next. The role that Multnomah County is played is multifaceted. So one role through our health officer, Dr. Jennifer Vines, who puts out clinician guidance. And one of the things she's done in that clinician guidance that goes out across the county to providers is include Black, Latinx, Indigenous, and African American people in that priority definition. Before, it had underlying health conditions or age or where you would work in terms of healthcare settings. So it really elevated the priority of testing, and which then asked health systems to expand their definition of priority populations. Another thing that did was expand the definition of essential workers. So not just healthcare workers, but other workers who are on the front line. So that's one way in terms of public health and using that influence. Another way here in the health department is we do have testing through our clinics, our federally qualified health centers. And in that, we work with, as a safety net, we work with Black and Brown communities and many others. And we're looking at how to prioritize testing and make sure that testing is available, and what are the different creative ways that we can do that. Some of the ways we've done that is offering testing outdoors and working with people to do that as well. And then another way is that we're assessing where the gaps are. We're wanting to hear from communities. We're wanting to understand who's being turned away, what are the demographics of who's being turned away. We're wanting to understand who the negative tests are so we can get an accurate picture of who's being tested, what's the race and ethnicity of who's being tested, and where do we need to plug those gaps. So working in partnership with health systems to ensure that the testing that they're already doing, that people know where that is, that they have access to that, and that whatever barriers we're finding, we're working that out.
Dr. Dudelau, we have a question from Nick Budnick at the Portland Tribune for you. Nick says the data on the dashboard says unknown on race and ethnicity at 8%. His impression was that the figure was much higher, and you seem to indicate that too. Could you talk a little bit about that unknown category?
Sure. So I want to also, reiterating that the dashboard only shows data on people that have been tested. And so we know a very small proportion of county residents have been tested. And so, keeping that in mind, the unknown category on there is either people who have refused to give their race ethnicity, or they're still waiting to be interviewed. So the ideal is that every positive case in the county, they will have a case investigation. And during that case investigation, they will be asked what their race ethnicity is. Basically, the Real D questionnaire will be administered. And so that unknown category, is probably higher, but all of the categories are probably higher. And we'll see that with increased testing. But for now, what we, that category, as I know, is people who have refused to give their race or ethnicity, and people who have not yet been interviewed, not yet had the Real D questionnaire administered.
I would add too that there's more unknown data for negative tests. So as Dr. Dudelau pointed out, we may get a positive test that might have had unknown data, and then we're able to clarify that data through talking about them. But for the tests that are negative, where we're not following up with people, there's much more unknown data in that set.
We have another, Kate, I'm not sure if you have one, but I've got another one, a follow-up from Nick Budnick at the Portland Tribune. He's wondering if you could help him understand the difference in the overrepresentation of Latinx versus Black people in the data dashboard. Thoughts, theories, or research you could share about what we're seeing, just even at this early date.
So I guess I'll speak to that. Seeing the overrepresentation of Black folks and Latinx folks, it goes back to what I was saying about Black, Indigenous people of color being more likely to have essential jobs, and essential jobs where they can't take time off, right? They can't take sick leave, and that they have really close contact with other people. And so that's what we're seeing, is that among Black, Indigenous people of color, Latinx people of color, they are more likely to be exposed because they are in these positions where they are more likely to be exposed to people that may have coronavirus, and they don't have the option to work at home. And so they have to be out there working in the grocery stores, doing the janitorial positions and things like that. We see Black and brown people more represented in the cases and even the deaths because of the underlying conditions. So going back to the disparities that we do see in chronic disease. And these are really well established in the literature. I can give you a long reference list. Racial disparities in chronic disease and heart disease, diabetes, lung disease, are very, very long-standing and predated COVID-19. So, what we're seeing in the data, a lot of us, all the EPIs that I work with, we are not surprised, because this actually is showing what we have known all along.
We've got a question from Alex at the Mercury. I'm curious if maybe this is for Rachel Banks. Does the county plan on adding data to that dashboard that indicates positive cases from jails or prisons, maybe congregate settings as well?
Yeah, I think that that's a question. It's something that we're concerned about, always looking at congregate settings, and have done a ton of work in our response, making sure that places where people are in congregate settings, shelters and whatnot, that there's adequate spacing. I think what for us, there's a thing to how much data we need to put things out. And so right now we have on our dashboard information about homelessness, which is one thing that we've added. I think we'll continue to explore what data comes in as we see if there is cases in jail settings or with inmates.
I've got one more question, which is, can you talk a little bit about what, based on this initial, how you might be working together going forward in this arena?
Yeah, I can go ahead and start us off. I think, one of the things about building a relationship, as many people know, is it takes a long time to build a relationship. And since we've been building relationships steadily with Multnomah County Health Department over the last handful of years, what it allows us to do is to be able to be responsive as a coalition and as an organization that has connections with other folks across the Tri-County region and the state, to be able to hear information from our partners within the County Health Department and then be able to disseminate that information. And it's not just about the information being disseminated, it's about whatever subsequent actions happen after that. So a number of our organizations, like OHE, are independent advocacy organizations. So we kind of our wheels start turning about the things that we need to be advocating for to ensure that our communities, are represented in these data. Not that we want to see them represented, but we want to see them, right? We don't want to see them as part of the 50% of unrepresented, unknown, other, category. And so this is an opportunity for our organizations to start engaging in community-based and community-led advocacy efforts, community in led and oriented strategies and solutions. And I truly believe that when we bring those solutions back to Ms. Rachel, to Dr. Doldalau, and say, here's what we're hearing from our communities, that they're going to try their hardest to ensure that the solutions that community members most impacted have come up with are solutions that we can center in the further mitigation of this particular disease and pandemic.
Thank you, Zini. And I'd add a couple of things to that. I mean, one of the things that we've done in our overall response in our role in Multnomah County is to lead inclusively with race. And that means adding Black, Indigenous, and people of color to our definition of vulnerable populations and priority populations. And so that as we are making decisions about resources and whatnot, that we want to make sure that we're looking first to those vulnerable populations, including those in senior care centers and a variety of other things. Another is having conversations with a variety of community-based organizations and community members. We have a liaison structure where we've been getting a lot of information for folks, but it's very important to me, and I have a fierce sense of urgency around taking that information and rolling that into action. And in order to do that, we need to hear from folks what's most important and where do we want to start. We know this is a long haul, and that there are many, many needs that folks are experiencing that we need to plan for. At Multnomah County, we're not going to be able to solve all of those, but once getting those plans together and working with community and then having the conversation of who can do what, because we believe that coming together, we can change the course and change some of these disparities, and we will fight our hardest to do that.
Rachel, this is a question from Julia Silverman at Portland Monthly. She's asking about whether we're planning to release a breakdown of data by zip code. There's a second question, but I'll let you answer that one first.
Yeah, one of the problematic things about zip code from my perspective, there's a number of things. One is zip code is where somebody lives and it doesn't tell you where the exposure is. And so we talk a lot about this false sense of security, about knowing where the infection is. So that's one thing that's important to consider. We're more concerned with where people are being exposed than perhaps where they live. Another piece is really wanting to be thoughtful about what the potential unintended impacts of that are. We have seniors and folks that need meals delivered. We have folks that are at home that need services in their communities. And the thought that perhaps a zip code that doesn't even necessarily talk about where the exposure happened could stop somebody from getting the resources that they need is something that really weighs very heavily. The other is we are mindful of, once again, to that data piece of what are the numbers, and wanting to make sure that the numbers are such that we're protecting people's privacy. So at this point, I think zip code can be very problematic. And I'm more concerned with where are the places that people are being exposed, and how do we work with those places to protect folks? How do we make sure that if people are sick, they can stay home? All of those sort of things are really more at the forefront.
Thank you so much. And Julia had a separate question. This about testing. Is there a way to determine what percentage of those tested are Latinx, Black, Indigenous? And so is there available data on that, Dr. Dovala?
Yeah, so we actually do have the data on the positive test, but also the negative tests. But once again, I think I mentioned that when it comes to the electronic lab records or the testing records, half of those lab tests are missing race ethnicity. So we can probably get an approximation, but because there's so much missing data when it comes to the lab tests, it will be probably, we can get an approximation, but it probably will be something that we have to work on because of the large amount of missing data, but also needing to ramp up more testing. But we do have access to the positive tests and the negative tests.
Any last questions? I don't see any more chats. Okay. Well, thank you all for joining us. And one more. Great. I think that sums it up. So thank you so much. Thanks for joining us, everybody. And have a great weekend.